All right, let's continue. We won't do the entire chapter 29. In fact, we will only discuss nose bleeding, particularly emergency care for nose bleeding, as well as sleep apnea, and that should be it. Oxygen therapy will be discussed in another semester. All right, nobody really dies from a nosebleed. However, it can, nosebleed itself won't. However, the only way a patient will die is probably if they aspirate because of the bleeding. Just read the most common causes. So these are the common causes of a nosebleed. But our focus really is on this chart 29-5. So how do you care for someone who is bleeding from the nose? So universal precautions, if you remember when you were a kid, how were you managed when you had a nosebleed for those who had experienced one? What were you told to do?
Lean your head back.
Lean your head back, right? And then?
Pressure.
Put a copper coin on your forehead.
Yeah. So obviously, whoever told us to do that wasn't using best practice, correct?
Right.
Yeah. So, but you know, we didn't know any better, so everybody did that, right? So the correct thing to do really is to lean forward, so to prevent aspiration. I've never really had a nosebleed, so I don't know how that feels like. I have one daughter who gets nosebleeds, I would say frequently, but she gets them, you know, every summer or winter, maybe once or twice every year. But that's about it. Well, I did have a severe bleeding after a tonsillectomy, though. Yeah, so I had a experience also, but it wasn't from the nose, but it was from the throat. It's a scary event, so reassure the patient. Apply direct bilateral nose, so next to positioning, leaning forward. Apply direct pressure to the nose for 10 minutes. So I think we were told to pinch the nose bridge, right? But obviously that's a bone, so we can't do anything about that. It's really the nose that we apply direct lateral pressure to. And if possible, we do ice or cool compresses. I had one patient who, remember those NOACs, the novel oral anticoagulants that we discussed under DVT? No, the Pradaxa, Argot, Xarelto Eliquis. Do you know what I'm talking about?
Yes. Yep.
So the patient was on those, and obviously those drugs have no antidote, right? So the patient was bleeding. She was bleeding for pretty much the entire shift. The poor lady had no sleep at all. So I came in 11 p.m. to cover a weekend supervisor job. And this patient literally did not stop bleeding. From the start of my shift, she already started bleeding until I gave report the next morning. She was still bleeding. And we did call the doctor, and he just said, you know, nothing new. He did just apply pressure. He didn't recommend taking the patient to the hospital at all. It finally did stop bleeding after I gave report, and then the patient went to sleep finally. But she wasn't really bleeding profusely. It just wouldn't stop bleeding. So, however, if we had not applied pressure and employed these, we did put ice. Well, not ice, but well, yeah, it was in a Ziploc bag, and then we wrapped it with a towel. So yeah, it was ice. It was pretty much a cool compress. And we did that all night. So we took turns. It was between me, the LPN, and CNA. So we just took turns. Everyone who uh, had a break. We couldn't really leave the patient because she was elderly and of course scared. So we had to stay with the patient the whole time. And we did this, exactly according to the textbook. Loosely packed her both nares with the gauze. She had no problem breathing through her mouth. She was very cooperative at the whole time. But like I said, they don't really die unless they aspirate. Okay, so that's what we were trying to prevent during that episode. And that's pretty much it. These procedures here, like balloon tamponades, we employ this only in the ER. So they put these here for typically fractures to stop acute bleeding. So these are for arterial bleeds, but we rarely do these inpatient. So these are just to stop the bleeding in the ER. Short-term interventions. And that's about it. I'm going straight now to any questions on nosebleeds. So again, the questions will just be on that chart, emergency care. Next is OSA. Sleep apnea is common in obese patients. In fact, that's one of the risk factors. So what causes obstructive sleep apnea? Obesity, a large uvula, that thing hanging at the back of your throat, a short neck, smoking in large tonsils or adenoids, or pharyngeal edema. The short neck, of course, accompanies usually obesity. Somehow, as you gain weight, your neck gets shorter. Sleep apnea doesn't really cause death. However, the complications that lead to it can. This will lead to heart failure, dysrhythmias, and that will be what's going to cause um, mortality. Sleep apnea itself won't. The patient stops breathing for about 10 seconds. So this is the description of the disorder. The patient typically is not aware because they're somewhere between awake and dreaming when this happens. However, since the patient awakens several times during the night, and like I said, so they're too sleepy to remember, so they fall right back to sleep after the episode. But since obviously, is the patient going to ever reach rapid eye movement stage of sleep if they frequently awaken during the night? No. So as a result, the patient's symptoms, their only symptoms, because they won't know they're sleeping, so they don't know if they have sleep apnea. Usually the partner or a family member notices it. The snoring wakes the partner up and notices it. No, you stop breathing when you sleep. Of course, the patient will say, "Oh, I don't know, I was sleeping." Okay, so the only symptoms they feel when they wake up is they feel very tired. They feel like they've never slept at all, even though they slept for 8 hours, but the sleep was never continuous. It keeps interrupted by the awakening, because again, you know how it goes that you can't really kill yourself by holding your breath because it's not possible. Does that make sense?
Yes.
Yeah. So generally speaking, our breathing is an unconscious um, process, right? Meaning we don't have to think about breathing. And in fact, if you um, and I do this all the time when I have enlarged or inflamed adenoids. When you get a bad cold and you can't breathe, you get a really stuffy nose. So that's what happens. Your adenoids are inflamed and they obstruct your nasopharynx, or they obstruct your nasal passage. So you can't breathe in through your nose. So what I do is close my mouth, and whatever happens, I will never open my mouth to breathe. You'll find that your adenoids will suddenly open up. Have you ever tried that?
Yes.
Yeah, I do that all the time. If my nose is clogged up, I close my mouth and then I just force it. I mean, I don't have to bring any effort, but when you come to a point that you're suffocating already because you can't take a breath, the adenoid, you'll see that the adenoids would suddenly open and then your nasal passage is now open. I think it's related to that as well. That it's impossible uh, to hold your breath, okay, and not breathe. Your autonomic nervous system always kicks in and then forces you to take a breath. How do we diagnose it? Let's finish the signs and symptoms first. So like I said, this is the only thing the patient complains about. They wake up tired as if they never slept at all. There is a checklist. It's available in most general practitioners. If you see a family practitioner, they have this checklist that they can easily score you if you have sleep apnea. It's about 10 or 12 questions, and they score you based on your responses. Um, Here, so yes score to fewer than 3 items is low risk, and if you score higher than 3, then you're at risk for sleep apnea. The diagnostic test is a sleep study. Here, the most accurate test is a sleep study. You literally sleep. So they'll take you to a sleep center, and guess what you do? Sleep. And while you sleep, they will be monitoring you. Okay, of course, this is scheduled um, at the sleep center, and then, but however, there's a problem usually with insurance. Not all insurance covers this. I don't know why. Um, I mean, I have decent insurance. My insurance never covered it. I could never explain why. Probably because of my score. My score was probably not high enough. I don't know. But my doctor did recommend it. I got a um, script for it, but I never got a approval. Interventions is of course our causes were obesity, large uvula, what else? Enlarged tonsils or adenoids, and what was the other one? Or pharyngeal edema or smoking. If they can be corrected, that might be enough. But in the meantime, though, the patient has to sleep better. Okay, that's the more pressing condition because the complications here would be, like I said, heart disease, dysrhythmias, and heart failure because of pulmonary hypertension. The patient with sleep apnea will have a high resistance in the lungs, making how what happened to the patient with COPD that they develop right-sided heart failure. So they'll have the same complication here, this time caused by pulmonary hypertension from obstructive sleep apnea. So therefore, our main goal here is to let the patient sleep through by not allowing the airway to be obstructed. So therefore, no sleep apnea, no airway obstruction, they won't have apnea, they'll sleep through the night. The only device commonly used is a CPAP or a BiPAP. We do have innovations now. I heard it on the radio. I forgot the name, but it's a small device implanted inside the nostril. And I haven't read up on it yet, but it seems to open the nasal passage without the need of a CPAP or BiPAP. But again, it hasn't reached the textbook, so I don't know if it's universally used or if it's just something used here locally in New York. I've only heard about it on the radio. I don't know if you guys have Heard about it? I can't remember the name. Anyway, so the purpose of BiPAP CPAP, this is not a ventilator. Okay? This does not deliver breaths. What the machine does is deliver pressure. There are two types, so we have BiPAP, CPAP. In BiPAP, the name is bi-level positive airway pressure. So it's blowing in pressure. They're not delivering a breath. It's not a mechanical ventilator. It only delivers varying levels of pressure. If it's BiPAP, that means there are two levels of pressure here. It auto titrates depending on the patient's breathing cycle. So during inhalation, wherein the pressure is negative, the pressure is higher. So the BiPAP machine delivers slightly higher pressure during inhalation. So when it's sensing that the patient's taking a breath, of course, the pressure becomes negative because the air is sucked in passively when we breathe in. So as the diaphragm contracts down toward the stomach, air is passively sucked into the lungs because because of the positive pressure of the atmosphere. When the machine senses it, it will increase the pressure. And of course, when the patient is exhaling, there is now higher pressure, or the pressure becomes more positive during exhalation. The pressure being delivered drops down. So making exhalation feel more or less natural. In CPAP, there is continuous positive airway pressure, meaning unlike BiPAP, wherein there are two varying levels of pressure which auto titrate as the patient breathes or inhales or exhales. In CPAP, the pressure remains constant. It's the same pressure blowing into your airway, whether you're inhaling or exhaling. The pressure, though, is considerably less compared to uh, a BiPAP. Um, as far as the level of tolerance, because this does get some getting used to, because we're not used to something being blown down our airway, right? It also depends on the delivery device. Traditional BiPAP CPAPs have a full mask uh, here through a face mask. It's a pretty large mask. It covers literally your face. They have smaller profiles, which the mask will only cover the nose or maybe a little bit of the mouth or just the nose. Okay, so they have different sizes mask. It could be a full face mask, um, which is strapped over your head, or it could be a smaller mask only covering the mouth and nose, or only the nose. The drug mentioned here isn't really for sleep apnea. This is more for the sleeplessness. It's the same drug they give for narcolepsy, just to keep the patient awake. So this is more like a stimulant, just to keep you awake, so you can do your job, um, go to school, okay, do what you're supposed to do. Um, and like I mentioned earlier, if possible, we can eliminate the causes to alleviate the obstruction. So pretty much we're going to prevent these structures which are causing airway obstruction from doing that. So the doctor will either remove the tonsils or maybe partially remove the adenoids or cut the uvula, um, maybe totally or maybe just shave it down. I don't know exactly how they do it, but those are possible options as well. But most people just live with BiPAP, CPAP. You have no problems with that. The only problem with anything you put over your nose or mouth is hygiene. You do need to keep these things clean. Just like the mouthpiece of your inhalers, whether DPI or um, MDI, they just need to be kept clean. And the current recommendation for CPAP and BiPAP masks, they have to be cleaned every day. they're not that hard to, I mean, they're not that easy to clean though. So that's probably the reason why these patients may get respiratory infections from the equipment because it's, I mean, it's a long hose, you know, it's very cumbersome to clean. Although we see on TV, there are products now they're selling which keeps these equipment clean very easily. Of course, that depends if you have money. This is all the end of the topic. I'm not really going into sarcoidosis, laryngeal trauma, or airway obstruction. They will be covered under emergencies, like airway obstruction, you do the Heimlich, so that's under emergency. Do they still do this in a BLS class?
Yes.
They do, right?
Yep, they did for me.
Okay, all right. So that's another reason. It doesn't really need to be tested here because this is part of your annual, your every 2-year BLS recertification. Any questions? We're done. Unless you want me to start with cancer, we're done for the night. You want to begin with cancer tonight? Chapter 21?
No.
No from Selena. How about the rest of you?
No.
Like Mr. Atkinson's ready?
No, he's not.
Gabriella said yes, right?
I'm with it, but let me not go
Nope.
against the class.
How about Shamika? Shamika is speechless.
No.
Make
I
the
don't-
answer.
They're not.
How about Miss Lindsay? All right, I think it's majority. All right, unless you have questions, have a good Tuesday night. And quiz next week will be on TB and COPD.
Okay. Thank you,
Thank you,
Professor.
Professor.
Have a good one.
Thanks, Professor.
Professor, I do have
thank
a
you.
question actually, but not for everyone.